Welcome to the deep dive. We are really thrilled to have you with us today because we're venturing behind some very heavy locked doors.
Yeah, literally locked doors in this case.
Exactly. I mean, when you think about medical training, there is this, universal fascination with it. We've all seen the television dramas.
Right, the endless hospital shows?
Right. But usually when we picture a medical diagnosis, we imagine precision, like a broken arm, a jagged white line on an X-ray, and a doctor pointing at the film saying, there is the problem.
It's very visual, very concrete.
Yeah, exactly. But today, we are stepping into the world of the human mind. Neurodevelopment, trauma, all of that.
Where the X-ray machine is essentially useless.
Completely useless. The diagnostic landscape is so murky, and the navigators of those waters as psychiatrists are tasked with fixing literally the most complex organ in the known universe.
It's a massive undertaking.
It really is. And what you rarely hear about is how those navigators, learn to survive those waters themselves.
Because that survival process is entirely hidden from the public.
Oh, for sure.
We expect physicians to emerge from training fully formed, perfectly empathetic, and, well, infinitely resilient. But the reality of transitioning from a medical student to a fully fledged psychiatrist involves it's a psychological crucible.
Which brings us to the really fascinating material we have for you today. We are pulling directly from the third edition of A Resident's Guide to Surviving Psychiatric Training.
Published by the American Psychiatric Association.
Yes, the APA. And our mission for this deep dive is bringing this guide to life. We aren't just summarizing a clinical manual for you. We are using this text as a literal map to navigate the hidden high-stakes wilderness of becoming a psychiatrist.
Okay, let's unpack this, because we all have this preconceived image of what a doctor is.
Yeah, the crisp white coat.
Yes, the white coat, the stethoscope, draped perfectly around the neck, the clipboard. But the moment you open this guide, it just shatters that illusion.
It really does. Because this specific text stands out. It's not a textbook about neuropharmacology or diagnostic criteria.
Right. It is an anthropological survival guide. It was written by psychiatric residents, fellows, and early career psychiatrists, specifically for the next generation of trainees.
By the trainees, for the trainees.
Exactly. And it reads with this profound self-awareness about the absurdities, the dangers, and the emotional toll of the profession.
It reveals that for a psychiatry resident, the daily reality is just chaotic. They are tasked with healing the human mind while they're actively trying to preserve their own sanity.
Which is no small feat.
No. And the guide points out that this struggle begins on day one with a massive identity crisis.
Yeah, consider the trajectory here. A brand new psychiatric resident has just completed 4 years of grueling general medical school.
Right, doing everything.
Everything. They spent countless hours in anatomy labs dissecting cadavers. They delivered babies in the obstetrics ward. They managed congestive heart failure in the ICU.
They were trained to be generalists.
Precisely. Then suddenly they match into a psychiatric residency program. The heavy doors of the psychiatric ward close behind them, and they are essentially isolated from the rest of the medical hospital.
The guide explicitly calls this out as the real doctor dilemma. I mean, the first chapter is literally titled, Psychiatrists Are Real Doctors Too.
Which tells you a lot about how they feel.
It really does. It feels like spending 4 intense years becoming fluent in a highly complex language, the language of the physical body, only to be moved to a country where you never speak it.
That's a great analogy.
You have to wonder how fast they start forgetting the verbs and conjugations of general medicine,
What's fascinating here is that the atrophy of those skills happens remarkably fast if it isn't actively combated.
Really? That fast?
Oh, yeah. Historically, the medical field treated the mind and the body as 2 entirely separate domains, largely due to the way hospitals are physically structured.
Right. Psych is always in some separate wing or basement.
Exactly. But the guide emphasizes that this separation is a dangerous illusion. A psychiatrist must actively fight the system to maintain their basic medical skills.
Because the patients aren't just floating brains.
Right. Psychiatric patients are notorious for having complex, completely overlooked physical ailments.
The phrase the guide uses is, use it or lose it. In psychiatric training, a resident might only do 4 months of internal medicine or pediatrics and maybe 2 months of neurology.
And that's usually right at the beginning.
Yeah, most residents rush to get those requirements out of the way in their first year while the knowledge from medical school is still fresh.
And once those rotations are over, the isolation really sets in.
And that has clinical consequences, right?
Massive consequences. If a psychiatrist isn't comfortable taking a blood pressure reading, listening to a heart murmur, or performing a basic neurological physical exam, they can miss glaring medical issues.
Like what?
Well, a patient might be admitted to the psychiatric ward for a sudden onset mania or psychosis, but the root cause could be an undiagnosed hyperthyroid condition.
Oh, wow.
Or a severe urinary tract infection, particularly in the elderly, or even a brain tumor. The psychiatric symptoms are just the alarm bells for a physical fire.
So the guide strongly advises these young doctors to actually perform physical exams on their psychiatric patients, especially when they first encounter them in the emergency room or during an inpatient admission.
Which serves a dual purpose.
Right. It forces the resident to practice their physical skills, and it acts as a critical safety net for the patient.
Exactly. And to further fight that isolation, the guide provides these practical, almost guerrilla-style tactics for continuing education.
Yeah, they tell them to go rogue a little bit.
They do. They instruct residents to intentionally leave the psychiatric ward and attend grand rounds in other departments.
To show up at neurology.
Yes, to physically walk over to internal medicine or neurology, sit in the back of the auditorium, and just listen to complex physical case presentations to keep the vocabulary alive in their minds.
They also push the use of technology to bridge the gap. The guide points to apps like QXMD and review texts like the current series.
Because they don't have time for massive textbooks.
Right. The strategy is to pull articles and medical summaries into a format that a resident can browse during the rare, 5 minutes of downtime they might have between patient crises.
You can't expect someone working 80-hour weeks to read a 1,000-page internal medicine textbook cover to cover.
No, you'd fall asleep on page 2.
Exactly. It grounds the learning in immediate reality. The advice is to only read about the specific medical disorders that your current psychiatric patients actually have.
Oh, that makes sense.
Yeah, if your patient with schizophrenia also has diabetes, you use that opportunity to refresh your knowledge on insulin management.
I want to highlight a detail in the guide that I found incredibly revealing about hospital culture. It involves consultation-liaison psychiatry.
Ah, yes. CL.
Yeah, CL. This is the branch of psychiatry where the resident leaves the psych ward and acts as a consultant for patients on other medical floors, like a postoperative surgery ward or a bustling oncology unit.
It's a completely different environment.
Totally. And the guide notes that this rotation is where the psychiatrist can truly establish their identity in the wider hospital. And it explicitly mentions that even in programs where psychiatrists have abandoned the traditional doctor attire.
Which a lot have.
Right. They wear business casual or whatever. But the CL psychiatrists will put on the stereotypical white coat.
Because it functions as a psychological passport.
A passport. That's a great way to put it.
In a surgical ward, the hierarchy is rigid, and visual cues dictate how you are treated.
They don't have time to figure out who you are.
Exactly. By putting on that white coat, the psychiatric resident is signaling to the surgeons, the internists, and the nursing staff that they share the same foundational medical knowledge.
It demands professional respect.
It does, in an environment that might otherwise dismiss a psychiatrist as merely a feelings doctor. It is a deliberate, symbolic bridging of the artificial gap between the mind and the body.
To maintain that bridge, the guide even pushes residents to moonlight in general emergency rooms on their days off.
Which is intense.
It's wild. They are advised to maintain their basic life support, advanced cardiac life support, and pediatric life support certifications.
The BLS, ACLS, and PALALS.
Yes, those acronyms you constantly hear in medical dramas when someone is shouting for a crash cart. But doing that sounds utterly punishing.
It's exhausting just thinking about it.
I mean, you are spending your week learning the microscopic nuances of psychopharmacology, and on your one free weekend, you are intubating patients in an ER just to make sure you remember how to run a cardiac code.
It demands an extreme level of endurance. But the underlying philosophy, however, is that a psychiatric emergency can instantly transform into a medical emergency.
How so?
Well, a patient might have a severe adverse reaction to an antipsychotic medication, which can lead to cardiac arrest.
Oh, wow.
In that terrifying moment, the psychiatrist cannot freeze or wait for the internal medicine team to arrive. They must fall back on their muscle memory and act as a physician first.
The idea of maintaining that physical medical knowledge makes total sense when they are consulting on a surgical floor or moonlighting in the ER.
Yes, definitely.
But what happens when they go back to their home turf? We have to transition from this theoretical medical identity to The visceral physical reality of the psychiatric ward.
And it is a very physical reality.
It really is. The guide pulls no punches when describing the front lines. You aren't just diagnosing a patient, you are managing a dynamic, enclosed, and potentially volatile environment.
This is a critical pivot in the trainee's development. On a locked psychiatric ward, the clinical interview is not a passive event.
Right, you're not just sitting behind a desk nodding.
No. The resident is constantly reading the room, managing agitated patients who may be experiencing terrifying hallucinations or severe paranoia.
Here's where it gets really interesting, because the human psychology of the doctor becomes the focus.
Yes. The guide addresses how residents react when facing a threatening patient. It describes this phenomenon where a trainee will recognize that a situation feels deeply unsafe. The hair on their arms stands up, their heart rate spikes, but they actively suppress or deny that fear.
Which is so common.
They flex themselves to ignore their own anxiety and pretend everything is totally normal.
It represents a massive collision of biological instinct and professional identity.
How do you mean?
Well, the resident's entire self-worth is built around the concept of being a healer, a helper, a source of comfort. To consciously acknowledge that the person you are trying to heal might actually hurt you, it creates an intolerable cognitive dissonance.
So their brain just sort of rejects it.
Exactly. The easiest psychological defense mechanism is repression. The resident mutes their internal alarm system to preserve their identity as the fearless, compassionate doctor.
But the guide jumps in and warns that this repression is incredibly dangerous. They actually cite evidence showing that repressing your fear makes you significantly more vulnerable to being assaulted.
Which seems counterintuitive, right? You would think the brave, stoic doctor is the safest one in the room.
The mechanism behind that evidence is fascinating. When you repress fear, you don't just banish the emotion. You shut down the situational awareness that the emotion is trying to fuel.
Because fear has a purpose.
Exactly. Fear is an evolutionary tool designed to keep you alive. If a resident ignores their fear, they stop paying attention to vital environmental warning signs.
Like what kind of signs?
They might not notice the patient's fists clenching. They might miss the subtle escalation in the tone of the patient's voice. Or, and this is a big one, they might foolishly position themselves in a corner, blocking their own exit to the door.
Just completely ignoring the physical reality of the room.
Right.
So the guide argues that by acknowledging the fear, the doctor remains vigilant. It states that a psychiatrist who acknowledges their fear while simultaneously expressing a genuine desire to help the patient is actually statistically less likely to be injured.
Because acknowledging the fear allows the resident to adjust their body language and interview tactics.
They can keep the door open.
Yes, keep the door open, maintain a safe physical distance, and keep your tone calm and de-escalating. It requires the resident to hold two completely opposing truths in their mind at the exact same moment.
Which is incredibly hard to do.
It is. I am deeply committed to healing you, and I am actively ensuring you cannot harm me. Balancing genuine clinical empathy with tactical self-preservation is a tightrope walk that you just cannot learn from a textbook.
And while they are learning to walk that tightrope, they are simultaneously expected to teach others how to do it.
Oh, the teaching aspect.
Yeah, the guide dives heavily into the resident's role as a teacher to junior medical students. They actually reference The House of God.
The famous, highly cynical novel by Samuel Shem.
Right, the underground Bible for medical interns. And they bring up the oldest mantra in medical training: see one, do one, teach one.
That specific mantra was designed for procedural medicine.
Like surgery.
Exactly. You watch an attending physician place a central line into a patient's neck. You place a central line yourself. Then you teach a medical student how to place a central line. It works for mechanics.
But psychiatry isn't mechanics.
No, it's not. The guide deconstructs this idea for psychiatry, pointing out that psychiatric residents are tasked with teaching highly nuanced, invisible cognitive skills.
They are trying to teach intuition. They are trying to teach active listening, which, sounds easy until you actually try to do it.
It's incredibly difficult.
But the concept that stood out the most to me is the expectation to teach tolerance of your own affect. I mean, how does a sleep-deprived resident teach a 24-year-old overachieving medical student how to tolerate their own emotions?
It is arguably the hardest skill in psychiatry. Medical students are conditioned to be problem solvers.
They want a quick fix.
They want to prescribe a pill, stitch a wound, and cure the patient. But imagine a medical student sitting across from a patient who is profoundly, agonizingly depressed, or someone grieving an unimaginable loss.
There's no pill for that.
Right. And the student's immediate internal reaction is often extreme discomfort. Their instinct is to offer hollow platitudes or rush to fix the patient just to alleviate their own internal distress.
They want to stop the patient's crying so the student can feel better.
Precisely. Tolerance of affect means teaching that student to sit in the silence, to absorb the emotional pain of the patient without running away, without deflecting, and without trying to prematurely shut down the interaction.
Just being there.
Yes. The resident has to model how to be a steady container for someone else's chaos. You cannot rote memorize that kind of empathy.
No, it has to be experienced.
It requires live patient interactions, direct supervision, and intense, exhausting debriefing sessions after the patient leaves the room.
And as if managing agitated patients and molding the minds of medical students wasn't enough, the guide brings the resident crashing back down to the absolute drudgery of modern medicine documentation.
Yes. The endless notes.
Writing admission notes, progress notes, discharge summaries, it takes up a staggering amount of their time.
Documentation is often complained about, but the guide really reframes it as the vital connective tissue of the hospital system.
It's not just busy work.
Far from it. A progress note is far more than a diary entry of what happened that day. It serves as a clinical map for the next doctor taking over the shift, a strict legal document if the case ever goes to court, and let's be honest, the sole mechanism for hospital reimbursement.
Which keeps the lights on.
Right. The guide stresses the concept of authorship, clearly indicating who gathered which specific pieces of information and separating the raw data from the physician's interpretation of that data.
Because in psychiatry, the data is just conversation.
Exactly. In a field where the primary diagnostic tool is observation and conversation, a poorly written note can completely derail a patient's continuity of care.
So, a resident has to manage their medical identity, survive the physical dangers of the ward, teach students how to feel, and write flawless legal documents.
A lot of plates spinning.
You would think that constitutes a full-time job, but we are only halfway through the expectations.
Right into the fire.
Yeah, the guide now ushers the trainee into the academic gauntlet. Residency is not just employment, it is a rigorous academic program.
The clinical environment is only one half of the pressure cooker.
The other half is the books.
The academic expectations are relentless, designed to ensure that the resident is constantly expanding their knowledge base while simultaneously providing full-time patient care.
They introduce this looming, anxiety-inducing hurdle called the PRITE.
The Psychiatry Resident and Training Examination.
It is an annual in-service exam that tracks their knowledge and hangs over their heads constantly. To prepare for this exam, and simply to be a competent modern doctor, the guide highlights a brutal reality. Textbooks are effectively obsolete for cutting-edge treatment.
Textbooks are invaluable for foundational concepts, the history of psychiatry, the basic neuroanatomy of the brain. But the publication cycle of a major medical textbook takes years.
Though by the time you buy it,
by the time the ink is dry and the book is distributed, the chapters on psychopharmacology, novel therapeutics, or genetic markers might already be outdated. Modern medicine moves too fast for bound paper.
Which means the residents are forced to turn to peer-reviewed journals. They have to read the primary literature.
And primary literature is dense.
It is. It's filled with complex statistical analyses, and as we've established, these residents are already emotionally and physically exhausted.
To prevent the residents from drowning in data, the guide offers highly strategic advice for consuming literature.
It tells them how to read efficiently.
Exactly. It warns them against aimlessly browsing databases. Instead, it directs them to seek out topical literature reviews on platforms like PubMed, which do the heavy lifting of synthesizing multiple studies into a digestible overview.
A summary of the summaries.
Right. It encourages checking clinicaltrials.gov to see what therapies are coming down the pipeline. Most importantly, the guide insists that residents must transition from being mere consumers of research to active producers of it.
Which sounds completely unhinged when you look at their schedule.
It does seem impossible.
It's like asking a marathon runner to compose a symphony while they're at mile 20. I mean, they are working 80 hours a week, managing life and death crises, and the guide is telling them they need to design a clinical trial. It makes you question the sanity of the training model itself.
This raises an important question. Why is the system designed this way? Why inflict this massive cognitive load on trainees who are already stretched to their absolute limits?
There has to be a reason.
The justification lies in the ultimate goal of medical training. The field of psychiatry cannot advance, and patient outcomes cannot improve if the system only produces technicians who dispense pills according to a static algorithm.
They don't want robots.
Exactly. The objective is to forge physician scientists.
Doctors who don't just follow the rules, but question if the rules are actually working.
Yes. Practitioners who have the methodological training to critically evaluate new evidence, challenge entrenched clinical dogmas, and contribute original knowledge to the field.
To push the field forward.
The act of conducting research, organizing complex data, navigating the peer review process, and defending a hypothesis forces a trainee to elevate their thinking. It transforms them from a student into a respected expert.
Fortunately, the guide is highly pragmatic about how to actually survive this requirement. It explicitly tells residents, whatever you do, do not start a project from scratch.
Do not reinvent the wheel.
Right. It advises them to go directly to their department's website, identify faculty members who are already running established research labs, and basically ask to join their ongoing projects.
That is the most valuable piece of academic advice a resident can receive.
Really? Just tag along.
Yes, because medical research moves at a glacial pace. Designing a study, securing funding, getting approval from an institutional review board, recruiting patients, and analyzing data can take half a decade.
And residency is only 4 years.
A resident simply does not have the time. By joining an existing project, they can take on a specific, manageable role, like conducting a literature review or analyzing a subset of data, and they can actually see their name on a publication before their residency ends.
The guide even provides a roadmap of publications that are specifically receptive to trainee submissions.
It gives them a target.
Yeah, it highlights the American Journal of Psychiatry's Introspections section, which publishes brief, highly personal vignettes about the experience of training, as well as the resident's journal.
It also delves into the complex politics of academic publishing.
The unwritten rules of academia.
Exactly. The guide emphasizes the absolute necessity of academic mentorship, explicitly advising residents to enlist a senior supervisor as a co-author on their papers.
Just to have their name on it.
Yes, this isn't just about getting help with the writing. The guide frankly acknowledges that having an established, recognizable name on the paper lends instant credibility to the research.
Because they're just residents.
Right. It is a strategic mechanism to bypass the inherent skepticism reviewers might have toward a paper written solely by a trainee. It is how you play the academic game.
So imagine a resident has successfully navigated all of this. They haven't lost their physical medicine skills, they survive the psychiatric ward safely, they teach their students brilliantly, and they publish papers in top journals.
It's like the perfect doctor.
They are the perfect doctor, right? But the guide warns that none of that matters if you fail the next section.
The professional landmines.
Yes, we move into the unwritten rules. This part of the text focuses entirely on professionalism in the modern age, and it reveals how quickly a promising career can be derailed by behavior outside of the clinical realm.
Medical professionalism is a difficult concept to quantify because it extends far beyond simply showing up to work on time or wearing the correct attire.
It's deeper than that.
Much deeper. The guide frames professionalism as an immutable core of a physician's identity. It demands an unwavering consistency of character both inside the hospital walls and out in the public sphere.
And nothing tests that consistency like the modern minefield of social media.
Oh, absolutely.
The guide issues a very stark, explicit warning. Do not post any content anywhere that you would not want your program director, your senior colleagues, or your patients to see.
In the current era of chronic oversharing, this boundary is constantly blurring.
Everyone posts everything.
But for a psychiatrist, the stakes are uniquely high. The psychiatric treatment model relies heavily on the concept of the therapeutic alliance.
The bond between doctor and patient.
Right. The patient needs to view the psychiatrist as a stable, objective, calm presence, often a blank slate onto which the patient can project their own issues to be analyzed.
So if the patient finds out who you really are...
If a vulnerable patient Googles their resident psychiatrist and finds a public social media profile filled with extreme political rants, heavy partying, or erratic behavior, that therapeutic blank slate is shattered.
You can't unsee it.
The trust is broken, and the clinical relationship is effectively destroyed.
The guide then introduces a concept it calls mental toughness. It defines this as the strict requirement to not take things personally.
Which is incredibly hard.
It paints a picture of the daily friction in a hospital. An exhausted surgical intern snaps at the psychiatric resident over the phone at 3 a.m. Or a deeply paranoid patient misinterprets the resident's intentions and verbally attacks them.
It happens every day.
The absolute mandate from the guide is that the resident must absorb that hostility and be the bigger person every single time.
The emotional labor required to execute that mandate is staggering.
I can't even imagine.
The guide attempts to rationalize this by explaining the psychology of the aggressor. It points out that when a colleague snaps or a patient lashes out, their behavior almost always reveals far more about their own internal state, their severe sleep deprivation, their crushing workload, or their underlying psychopathology than it does about the resident's actual clinical competence.
I try to translate that to a normal workplace setting to understand the weight of it. Imagine having to be the bigger person every single hour of your job.
Right.
If a coworker yells at you because the copy machine is broken, your natural human instinct is to defend yourself or snap back.
Of course it is.
But the resident is forbidden from doing that. Instead, they have to perform a rapid, silent psychological evaluation of the person yelling at them, recognize the stress factors driving the outburst, and respond with a perfectly calibrated, boundless empathy.
And doing that requires immense energy.
The sheer discipline required to maintain that positive, de-escalating outlook when the hospital system itself is actively draining your energy reserves. It must be exhausting.
If we connect this to the bigger picture, it is outlining the unique foundational social contract of medicine.
The social contract.
Yes, the rules of professionalism are not simply about workplace etiquette or avoiding HR complaints. They are about preserving the public trust in the institution of psychiatry as a whole. You are dealing with human beings at their absolute most vulnerable.
To help young doctors navigate this incredibly complex social matrix, the guide recommends relying on structured, objective resources like the APA ethics primer.
It gives them some concrete rules.
Right. It provides a formal framework to map out the rigid do's and don'ts of professional relationships, particularly the delicate power dynamics between trainees and their senior supervisors.
Which can be a minefield of its own.
So we have spent this deep dive layering on these expectations one by one. The clinical demands, the physical dangers, the academic rigor, and this relentless, suffocating requirement for emotional professionalism.
It's a mountain of pressure.
Which brings us to the most critical and honestly the most emotional section of our deep dive. What happens when the human being trapped underneath all of this armor starts to crack?
When the system breaks them.
Yeah, how does the guide teach these young doctors to survive themselves?
This final section is where the text becomes profoundly poignant, because it drops the academic tone and addresses the human toll directly.
It stops being a textbook.
It does not hide behind jargon. It openly discusses the epidemic of medical resident burnout, and it highlights a terrifying paradox that the medical community has had to face. This burnout epidemic is raging despite massive systemic interventions.
They specifically mention the ACGME.
The Accreditation Council for Graduate Medical Education.
This is the governing body that sets the rules for all medical training in the United States. Years ago, the ACGME realized residents were dying, making fatal errors and burning out because they were working well over 100 hours a week.
Which is just biologically unsustainable.
So they mandated strict duty hour limits. They capped the work week at 80 hours. They assumed that working fewer hours would fix the burnout epidemic.
But the guide reveals it didn't.
It was a necessary structural intervention, but it failed to cure the underlying disease.
To explain why, the guide breaks down the clinical definition of burnout into a specific triad of symptoms.
A triad.
Emotional exhaustion, depersonalization, and a decreased sense of accomplishment.
Let's dissect that triad because it paints a vivid picture of the suffering. Emotional exhaustion isn't just being tired after a long shift.
No, it's much deeper.
It is the feeling of being entirely fundamentally depleted. The tank is completely empty. The doctor has nothing left to give their patients, their spouses, or their children.
And when that tank is empty, the mind deploys depersonalization as a desperate defense mechanism.
What does that look like in practice?
The resident can no longer afford the emotional cost of empathizing with suffering. So they subconsciously start viewing their patients not as vulnerable human beings in pain, but as obstacles.
They lose their empathy.
Completely.
Yeah.
The patient becomes a task to be completed, a diagnostic code to be entered, or worse, an adversary standing between the doctor and an hour of sleep.
That's heartbreaking. And the final piece of the triad is the decreased sense of accomplishment.
Right.
It is that insidious, creeping feeling that despite working 80 hours a week, despite sacrificing your 20s to medical school, nothing you do actually matters.
It's a profound sense of futility.
The patients keep coming back, the system remains broken, and your individual effort feels entirely futile.
The guide provides a sharp analysis of why this burnout is so incredibly difficult to combat from within the system. It identifies an unspoken rule woven into the fabric of medical culture.
The rule to just endure it.
The mandate to keep quiet and just keep working. This is a generational trauma inherited from the senior physicians.
The ones in charge.
The attendings who are evaluating these residents, who hold the power over their future careers, trained in an era before the ACGME duty hour limits existed.
They practically lived in the hospital.
They literally did.
So the residents are constantly facing this generational pressure from their bosses that implicitly says, I suffered through 120-hour work weeks without complaining, so you should be able to handle 80.
Complaining is a sign of weakness.
Right. Suffering is what makes you a real doctor.
For a century, suffering in silence was viewed as the ultimate badge of honor in medicine. But this survival guide actively, aggressively pushes back against that toxic legacy.
It really fights back.
It introduces modern, essential work-life balance strategies. It tells residents they have to redefine what success looks like in a realistic way.
Lower the bar a bit.
They cannot cure every patient's trauma, and they cannot publish a paper in every journal.
It gets incredibly practical about boundaries, too. It tells them to manage their technology. When you leave the hospital, put the smartphone in a drawer.
Disconnect entirely.
Stop checking the electronic medical record from your living room. Be fully present with your family and build a robust support network of people who have absolutely nothing to do with medicine.
Because isolation is the engine that drives burnout. If your entire universe is the psychiatric ward, the darkness of that ward will consume you.
The guide also touches on the brutal realities of trying to maintain a personal life during this decade-long training process. The chapter on romance, marriage, and parenting is surprisingly blunt.
It's very honest.
It acknowledges the clash between the biological clock and the medical training clock. They note, humorously but accurately, that there are no randomized controlled trials about the right time to have children.
And you can't perfectly schedule a pregnancy around your board exams.
You just have to embrace the chaos and figure it out.
The text also shines a vital light on specific populations within the residency cohort that face exponentially higher hurdles. It specifically addresses international medical graduates, or IMGs.
Right, the IMGs.
These are doctors who attended medical school outside the U.S. or Canada and are now training in the American system.
And they have it so much harder.
They aren't just learning psychiatry. They're often adapting to a completely foreign healthcare system, navigating immense cultural and linguistic shifts, and dealing with the perpetual, terrifying anxiety of visa statuses.
Always worried about being deported if they fail.
Furthermore, historically, they face lower pass rates on board exams due to systemic testing biases, meaning the academic pressure on them is magnified tremendously.
So, what does this all mean? With all of this pressure, the clinical danger, the academic demands, the burnout triad, the generational trauma, the visa stress, what is the ultimate safety net?
The guide makes a profound, explicit recommendation.
Yes. It says psychiatric residents should undergo personal psychotherapy themselves.
It is a remarkable recommendation for a medical manual to make. The guide explains that therapy is crucial for helping the resident distinguish between the normal, expected, albeit intense stress of transitioning into the overwhelming role of a physician versus actual clinical psychopathology that requires psychiatric intervention.
Figuring out if they are just stressed or if they are truly breaking down.
Exactly. Processing the trauma of the hospital with a neutral, trained therapist helps the resident understand their own emotional triggers and blind spots.
Because they have blind spots just like anyone else.
By understanding their own mind, they ultimately become a far more effective and empathetic psychiatrist for their patients.
But the guide doesn't stop at therapy. It goes into the absolute darkest corners of medical training. It confronts the reality of physician impairment specifically due to substance use disorders.
Which is a huge taboo.
Doctors have incredible access to narcotics and are under immense stress, making them highly vulnerable. The guide details the incredibly heavy, agonizing burden of what a resident must do if they suspect a colleague in their cohort or even their attending boss is impaired on the job.
The fear of reporting a colleague is paralyzing.
It could ruin their career.
You are reporting someone who might be your friend or someone who has direct control over whether you graduate. It requires immense moral courage.
But the guide doesn't give them a pass.
The guide is unwavering in its directive. Patient safety is the absolute priority. It stresses that ultimately intervening and getting an impaired colleague removed from clinical duties and into a treatment program is the only way to save their medical license.
And more importantly, to save their life.
Precisely.
It's about breaking the code of silence. And the guide empowers the residents to break that silence for their own well-being, too. It tells them not to passively accept systemic abuse.
They have to advocate for themselves.
If their hospital is violating the ACGME duty hour limits and forcing them to work dangerous hours, the guide explicitly tells them to speak up, to report the violations, and to actively fight for their own legal and physical protections.
When you take a step back and view this document in its totality, it represents a monumental, hard-fought cultural shift within the medical field.
It really is a shift.
The fact that the American Psychiatric Association, the premier institution of the profession, has published a survival guide that explicitly tells its trainees to seek out therapy, to report labor violations, to turn off their phones and go be with their families.
It's unprecedented.
It signals that the culture is finally, slowly waking up to reality. It is an acknowledgement that the old model of the indestructible physician is a myth, and that a broken healer cannot heal anyone.
It is a tragic irony, isn't it? The very people dedicating their entire professional lives to treating anxiety, depression, and severe burnout in the general population are simultaneously being crushed by those exact same psychological forces during their own training.
It requires an integration of the mind, the physical body, and the volatile environment that is truly staggering to comprehend.
It really is.
These residents aren't just memorizing diagnostic criteria or learning how to prescribe medication. They are learning how to become the actual instrument of healing themselves.
And that instrument requires maintenance.
An instrument under that much pressure must be rigorously, fiercely maintained, or it will shatter.
We started this deep dive talking about how much we all crave precision. We want the clean X-ray. We want the simple binary diagnosis. But the sources we've unpacked today reveal that becoming a psychiatrist requires navigating a world with absolutely no clean lines.
A lot of gray area.
It requires an incredibly delicate, terrifying balancing act. You have to maintain your general medical knowledge so you don't miss a hidden physical illness. You have to protect your physical safety on a locked ward while somehow keeping your heart open to the patient.
You have to survive the grueling academic gauntlet of research and exams.
And above all, you have to maintain an intense daily practice of psychological self-preservation just to survive the deeply flawed culture of medicine itself.
It is a profound journey of endurance.
It really leaves you with something heavy to think about. I mean, we expect these doctors to be the ultimate experts in human psychology. We turn to them when our own minds are overwhelmed.
They are the safety net.
But if the psychiatrists themselves, the very people who wrote the diagnostic manual on mental health, have to pass down a desperate underground survival guide just to maintain their own work-life balance and keep themselves from burning out.
Right.
What does that say about the psychological safety and the sustainability of the modern workplace for the rest of us?